All right, everybody, this is Dr. Ed Park. Thank you for joining us for our second webinar. This one will be about back pain. We're trying something a little new, and it has to do with projecting myself in this little corner onto the slide. See how that works. Okay, let's talk about the scope of the problem. 80% of people, it said, suffer significant back pain, and this is the #1 cause of consultations and problems to the healthcare system. Well, why does that happen? We'll discuss that in this lecture. Uh, the back pain, of course, increases with age and increases in severity. We have to think, what is the back? The back is a mechanical structure that is composed of bones, ligaments, and muscles. And all these have stem cells. So because they have stem cells, they're subject to this one diagram that I came up with for my first book. And you see here, when we see shortening telomeres in any kind of cell type, it causes DNA damage. That causes aging, dysfunction, and cell death, which will lead to depletion. And in different cell types throughout the body, we get depletion that manifests as Alzheimer's, Parkinson's, dementia. In the heart, it might be arrhythmias, valvular disease, atherosclerosis. In the eyes, macular degeneration, and so on. So all these ists, endocrinologists, neurologists, cardiologists, the gist of it is that actually we have one mechanism that is driving this. Now, of course, there are other aspects to this, but I still believe that telomere erosion is a final common pathway to creating all these diseases. So what is the back used for? Well, it's kind of fun to go back in evolutionary biology and we see that the fellow animals, not all of them have a backbone. Going back to these tube worms, they had some primitive form of a backbone. And then as we go along the family tree here, evolution says that different inventions were inherited by common ancestors. Someone invented a backbone, then jaws that gave us the famous jaws, great white, the bony skeleton, lungs, limbs, the amniotic egg, and down here in our family tree we have horses, which also have mammary glands. There are some things that chordata, our phylum, has, but we don't need to go into those. Basically, the backbone serves the back serves three functions. Structure, which means that the head is connected to the neck bone. And of course, the shoulders are connected to the spine. The ribs protect our internal organs, and they're connected to the spine, and the pelvis is connected to the spine. The function of the back is also neurologic. It runs up and down and is where the nervous system is protected and is where it's housed. That allows us to control and sense our entire body in time and space via these cranial nerves, peripheral nerves, and the autonomic nervous system, at least half of which is protected by the spinal column. This gives us real-time feedback, allows us to know how we're doing and monitor and adjust our internal state. And beautifully, of course, we have movement. This gymnast shows that the body can move in all axes, X, Y, and Z, twisting, rotating, jumping. And of course, this young lady will eventually become this old lady through processes that will cause back pain. It's important to review the normal anatomy. We see from these beautiful illustrations by the one and only Frank Netter, there are 4 curves when seen sideways. There's 2 curves away from the belly button in the cervical and lumbar region, and there are 2 curves towards the belly button, if you will, thoracic and coccygeal sacral. This is actually how these segments are defined. When we look at the individual bony segments, what we have is bone, of course, articulating above and below by these gel discs. These discs are fibroannular discs, and inside they have a jelly. It's a beautiful design. Long before Reebok came up with this, we had this in our spine. And of course, every spinal segment articulates in 4 places, 2 above and 2 below by these facet joints. Finally, the back is held together by ligaments. Ligaments such as the anterior longitudinal ligament, the posterior longitudinal ligament, the ligaments flavum, and these ligaments between the spines called interspinous and supraspinous. Also, we have fine muscles, tiny muscles, adjusting and maintaining posture, and very powerful muscles in both the neck and the lumbar region allowing for control of movement of the upper and lower extremities. And I think this is how we get into a lot of problems in these two particular areas. Keep in mind the cervical and the lumbar are our areas of biggest problem. So doc, why does my back hurt? Well, there are a lot of reasons why something that is old, aging, damaged, subject to friction, oxidation, malnutrition would age and get damaged. There are fractures in the bones. There's collapse. Of course, when you see an older person hunched over, a lot of that is attributable to osteoporosis. Instead of a nice cylindrical fresh beer can, the beer can becomes crushed. And indeed, Talia will talk to us a little bit about what happened to her at the end of the call. We also have damage that occurs to the disc. The facet joints also twisting and rotating a lifetime in 4 different places. These are subject to arthritis, as you might imagine. And the ligaments also can become damaged, as well as the muscles, giving us problems. So when you get this damage to these bones, discs, ligaments, and muscles, what we get is poor posture. Now, it's a little bit of a chicken and egg because poor posture can cause these things. So which came first? But what we see in the middle here is good posture. The head is held over the shoulders and pelvis, and that's over the feet. Nice. But what we see to the left and right are variations of poor posture. When the head is slumped forward, it puts undue stress on the neck muscles. When we have weakened abdominal muscles, we can get a sway back, the pelvis thrust forward, and tight muscles in the legs. This is all bad. And of course, bad posture will lend towards more damage. When you have damage, bad posture, we have back pain and we don't want to go out and exercise. And that's the third part of this. When we don't have the flexibility, we don't get the exercise, so the bones are not stressed. We need stress to build bone in a constant remodeling, just like astronauts have to find some way to stress their bones, otherwise their bones will dissolve. So we need to stretch those ligaments without injuring them, and we need to build the muscles, both the muscles in the spine and the muscles in our so-called core, the back and abdomen, to maintain that good posture. We look at the person illustrated here on the right, bending over. We have 4 color-coded regions. The pink is the cervical or neck roots that come out from the spinal cord, and the yellow is the lumbar. And these are areas of problems usually. This is why people usually present to the doctor if it's not intrinsic back pain. What does this look like? It feels like tingling, numbness, weakness, or loss of coordination in the upper extremities or in the lower extremities. And it's often one side if it's impinging upon one root. It can be discogenic, caused by disc protrusion or bulging. It can also be caused by bone spurs, as illustrated here. A bone spur is a little outcropping of the bone, and it's pinching that nerve, causing us problems. The disc, of course, is shown here in 2 colors, the disc bulging out, pushing on the nerve, seen here sagittally, and seen here axially, pushing on the nerve. But muscles also can cause things that would, you would think, hey, I got sciatica, I got back pain. But muscles can also be a little bit of a red herring, so to speak. A classic example would be piriformis syndrome. Here we see these nerve roots coming out of the lumbosacral area and converging on this largest nerve, the sciatic nerve. And as it passes underneath the piriformis muscle, which is a hip rotator, it can get impinged if that muscle is too tight or in spasm. So what we can do there is massage it. There are different therapies. It is treatable, but this, of course, is not back pain per se. Another common but underdiagnosed condition, as I think Dr. Greg Gerber is on the line, who can attest, is psoas syndrome, meaning I mentioned there are strong muscles attaching to the vertebrae, right, in the lumbar region. Here's one. It's called the iliopsoas. It adducts the thigh towards the spine, and we see that if this is in spasm, it'll fold this segment and this segment towards it, causing a bulging out. Simple mechanics. So as this disc protrudes out, it impinges on this nerve, mimicking sciatica. So if a person has pain shooting on their left buttocks, it could be this psoas syndrome. And what is the treatment for that? Well, she's doing it. She is stretching out her right side psoas because the right is pulling, causing protrusion towards the left. Spinal stenosis is another common problem, and it's a bit of a misnomer, and I'll explain why. Because there is no spinal canal per se. The spinal canal is a potential space caused by the stacking of vertebrae. So if we look at this stack of rubber tires, there is no tire canal per se. If the tires are in alignment, there's a nice round cylindrical canal. If not, we get what would be spinal stenosis in our case. Spinal stenosis can be discogenic from the disc, from ligaments, or from alignment. A case here of discogenic spinal stenosis is shown here, where the disc is bulging down. And you know this is the lumbar region because the artist has quite rightly shown that the nerves are free here. They're not a cord below about T12L1. They're a cauda equina, or a horse's tail. And we see the bulging. Nevertheless, it causes impingement, causes spinal stenosis. OPLL is ossification of the posterior longitudinal ligament. Remember I told you there was a longitudinal ligament running down there, often associated with calcification or ossification of the ligamentum flavum as well. This can happen with higher incidence among Asian people. The cause is largely unknown. And either way, if you get it from disc, from the ligament, or from sliding, as it's shown here in the very, very common L5 to S1 subluxation or spondylolisthesis, what we see is relative to the lumbar spine, the sacrum is sliding back, or vice versa. And as the grade goes up, the severity goes up. So any way you get pressure on the cord or the cauda, you can get progressive symptoms. And the final pathway is when you lose bowel and bladder control. This is, of course, a very bad thing. In the neck, it manifests as pain, numbness, tingling in the hands and the arms, usually symmetrically. In the lumbar region, you get pain or cramps in the legs, especially after prolonged walking or standing. And it can be relieved by sitting forward or by resting. Why would that be? Well, here, if there is a narrowing of these tires and you stand up or exercise, the normal lumbar lordosis is accentuated, causing further compression. But if you bow forward, say like in a Japanese way, it straightens out the canal, less pain. So this is sort of a good test for spinal stenosis. We're kind of wrapping up here. We just talk about the treatments for back pain. So 80% of us get it. How can we treat it? Well, the adage holds true. An ounce of prevention is worth a pound of cure. So if we think of the back as this incredibly finely tuned mechanism with gears, like an interior watch, we don't want a rusted watch. We want to keep our clock clean, so to speak. And a good example of this is a patient of mine who at 65 was doing back bends. She has a video on YouTube where she does this 21 times from standing to a wheel. Now, this is something that 99% of us at any age can't do. It requires a lot of flexibility in the back, a lot of core strength, and it's amazing. And she did this through maintenance, which brings us to our next point. Treatment for back pain is optimization. You have what you have, but in the case of Deborah, she ate well, she exercised, she practiced a lot of things that would keep her healthy. And so keeping that clock clean means looking at your supplements. In most cases, people, like in Hawaii where I'm at now, they get sun, they probably don't need a lot of vitamin D. K sometimes makes vitamin D more effective. There are other supplements which arguably could help with bone health. But a lot of people, like a patient I treated last week for back pain and sciatica, she had been off estrogen for 8 years because of miscommunication with her pharmacist and retired doctor. And of course, most people would believe that the estrogen is the beneficial portion of the estrogen progesterone, staving off osteoporosis. So look at your hormones. A lot of meds can cause osteoporosis, especially glucocorticoids are known for that. And other things like thyroid medication out of balance, high or low, can also cause degeneration of many things. When it comes to treatment, there are 3 good treatments. Now, when you talk about good treatments, it's a Faustian bargain because like the watch repairman will say, you know, you can't really go in and replace, in most cases, what's wrong. So they're taking stuff out or reducing the functionality. A good example would be a very common, safe and effective microdiscectomy. If you can avoid it, somehow do, but if you need to have it, what they do is they take a cylinder and they gently displace the nerve and they go in and they take out the offending piece of the disc, relieving the pressure. A little more severe would be this middle procedure called laminectomy, where they go in and they remove some of the bone. And this can be grafted with cadaveric, or it can grow back as well. When things are sliding too much and it's beyond repair, you need to do a fixation, which is called a spinal fusion. You can see that this hardware is inserted, thereby prohibiting that sliding or spondylolisthesis, the subluxation. These are three common treatments. Of course, you'd much rather be in the first two of prevention and optimization. Finally, I need to reiterate that nanovesicle signaling or exosomes are not FDA approved for treatment of back pain or any of its associated conditions. Now, having said that, standard of care in this country is often epidural steroids for low back pain, which is also not FDA approved. It might shock you to find out. In fact, there's never been an FDA trial of steroids in low back pain, and in many countries, it's actually considered dangerous and frowned upon by their regulatory agencies. Yet it's very, very common procedure because, like quite frankly, it causes momentary pain relief. If we look at the Cochrane Review, which are the sort of high priests of scientific evidence-based medicine, the reviewer recently said, with regard to epidural steroid use for low back pain, there is insufficient evidence to support it. And why would that be? Well, we know for 100% certainty that glucocorticoids cause osteoporosis. They are chondrotoxic, meaning they poison the collagen-producing cells, and they also decrease collagen synthesis globally. We know this from people with Cushing's disease. They get stria, or the weakening of the skin, stretch marks. It's very bad to take steroids in any high dose for any prolonged period of time. But I get a lot of pushback because people are afraid of putting stuff in their back, and rightly so. But let's try and allay some of those fears of the procedure that I do. So what we see here is a diagram of an epidural needle going into the epidural space, which is a potential space filled with some fat, filled with some veins. On the right here is the spinal canal, which is that sac inside that potential space of stacked vertebrae. Now, let's say this lady was undergoing a C-section. I used to be an obstetrician. And so if I said, oh, you know what, we're going to have trouble with this one. There's a lot of scar tissue, a lot of complications. We got to do some additional stuff. We're going to need her to be asleep longer, or not asleep, but numb for longer. They would do this, a combined spinal epidural technique. And I illustrate this because you see a tiny needle, sharp, going into the dura. Okay, that's a wet tap. That's going into the CSF and the sac of nerves. But you see this curved, blunt needle. It's there to introduce a catheter. So the catheter is there in case my surgery goes over 90 minutes and, just like a labor, 8 to 12 hours, you need to have continuous infusion of anesthesia. And I bring this up because it's very easy to find this epidural space, actually. At this level, the spinous processes are pretty horizontal, so you know where you're aiming. It's a big target, and you just use loss of resistance. As you go, suddenly, as you puncture the ligamentum flavum, you have a loss of resistance, and you're in the space. And it's very easy and very safe in my experience. Even Talia, even though we did get an inadvertent puncture of the sac and some CSF coming back, the complications are manageable. Now, is epidural puncture safe? In this case, I think it's pretty safe because even if we do intravenous injection, mind you, it's not like intravenous injection of anesthesia, which can cause seizures, respiratory depression. No, we put IV exosomes in all the time, and that's kind of our main modality. So safe, even if you put it into a vein. Why do people have back pain after epidural procedures? As an obstetrician, I saw it a lot. And it's because you got this catheter in there for 6-8 hours. They're writhing around. Maybe they're causing bleeding, scarring, damage. Anesthesiologists will tell you it never happens. I can tell you it does happen. Finally, the anatomy is pretty straightforward down here. As we see on this diagram, the crests of the pelvis are easily felt. And here's a patient I did last week. I marked her crests. And then you can go and you can use an ultrasound, but you don't really need to. You can feel where L5 is, L4. You mark the spines of those. You can feel where the sacrum is. And so you're pretty well assured that you're in the right area for injecting. Now, when you inject, of course, this is a potential space. It can go up and down, and that's what we want. We want it to bathe all those previously mentioned ligaments, the disc, the bony structures. And so the more it spreads, the better. In conclusion, the rainbow, which I see a lot now that I'm living in Hawaii, is a symbol of hope, right? So there is hope. We had the spinal epidural steroids, not a great modality. Again, not something I'd recommend. The surgery is not great. They're limiting movement and anatomy. But perhaps with the use of exosomes, which come from mesenchymal stem cells, we can coax a regeneration. And in reviewing my 24 or so cases last night, every one of them, every single person experienced some improvement. Whether they got to the point where there was no back pain, I think that's dubious. But remember, this is a very complicated structure. It's a structure that's being damaged over the course of a lifetime. It's aging, there are tears, there is fibrosis of the muscle spasm, and even every unit is like a mechanical feedback loop, so there could be damage to that as well. It's hard to fight malalignment, atrophy, aging, damage that's accrued over a lifetime. I sort of liken it to cleaning up a dirty countertop. If you told me, well, I'm going to run the sponge across one time and fix it, that's not going to happen. So, of course, it's obvious from my clinical practice and from my experience that younger people do better. An acute injury, a one-time thing, much better, and that makes sense. If you have an accumulation, expect improvement, but I would probably, if money were no concern, recommend repeated treatments, say every month, epidural injection for at least 3 months if you're looking to really significantly clean that counter. And of course, if you want to spend zero money, or at least $9.99, you can buy my book on Kindle, which explains how breathing, mindset, sleep, exercise, diet, they can all be leveraged using the science of telomerase activation. What kind of behaviors are good? What kind of behaviors are bad to keep that whole process of aging and deterioration, stem cell depletion from happening? So that concludes the talk. It's brief. We're going to try and keep these under 30 minutes. And we're very happy to have Talia on. So I'm going to go ahead and unmute her. Hi, Talia. Can you say something?
Yes, I'm here.
Wonderful. So I'll briefly recap for people that don't know. Talia met me in November of last year. She came to a conference I gave at the Royal Hawaiian. She sat next to my mom by serendipity. And my mom had an epidural injection. She said it was good. I don't know if you guys talked about that, but she was the victim of an accident water skiing in, I think, around June of 2019. She lurched forward. Instead of letting go of the rope, she held on, and it caused a sudden jackknife and a small crush, maybe about almost a centimeter crush visible on the x-ray of one of her spinal bodies, vertebral bodies, resulting in pain, loss of function, and also a crunchy sound, right? So you got the epidural injection. We did it in Ryan's office. At that time, it was a wet tap. There was actually CSF running out, and you had a bit of a headache for several hours. Tell us about how you felt before, after, how long it took to get better, and what you're doing now, please.
Okay, well, the process of having the injection with the exosomes was very smooth, very professional, and it was not uncomfortable. And I was very pleased and relieved about that because I didn't know what to expect. And I was able to budget for just one treatment, which is probably why my results were not as fast or dramatic. But at the time, of course, I did have pain after the accident for quite some time, and I didn't understand why until I saw the x-ray results, and there was a L5 compression fracture very clear in the x-ray, where the L4 and the L6 basically just crushed the L5 on one side. So it was understandable why I was in so much pain, and also there was a cracking noise every time I took a step walking, and that went on for quite a while. And after the exosome treatment, I believe that was in February, I was able to recover more quickly than I ever possibly could have without it. And within a couple of months, it wasn't as fast as you had other patients had experienced with you, but I think it was because I was only able to do one treatment. And gradually, the cracking sound when I was walking got more and more soft and quiet, until it disappeared entirely on a very gradual basis. And I'm so grateful for that. And the only soreness I have in my back now might be if I overdo yard work or something like that, and it's only muscular. There's no more spinal symptoms or pain of any kind. If I get my back sore, I know that I overworked the muscles, and I feel so happy that it's only muscles. They'll be fine. Thank you. Any questions on that?
Oh, sorry. Yeah, I've been talking on mute this whole time. Sorry. I want to say, yeah, thank you so much for taking the chance. I'm glad that it got better for whatever reason. I think, yeah, probably if we were to do multiple or stronger shots, it might have gotten better faster, but at least you're out there swimming and enjoying. And sorry, I was on mute, but I just said it's really your health and your ability to function. Like, you don't appreciate it until it's lost. And now you're able to swim and hike. And what else are you doing?
Well, I'm able to do really long walks up and down hills, which is wonderful exercise. It's great for breathing and oxygen. I'm so happy to be able to do that again. And swimming feels really great. Of course, that's always good for the body's alignment because it's weightless. And yeah. I'm just very, very grateful and relieved because an accident like this could have left me paralyzed. And that was my first fear.
Yeah, no, absolutely. You did great. And you're so on top of it in terms of health and nutrition, and that certainly helped. And perhaps you would have gotten here eventually, but the fact that you're able to reach this high level of functioning again at the age of what, 64?
64, yes.
64, yeah, it's great. And it's wonderful. You know, like I mentioned, it was just one injury and you were pretty healthy. So that all was on your side. So luckily, you know, I have people who are in their 70s, they get one shot, they feel better, but they're like, well, it didn't really work. Well, I'm 30% better. Well, imagine if you had done 3 shots over 3 months, maybe you'd be 90% better. But I'm hesitant to call that a failure in somebody with an accumulation of 70-something years of back damage, you know?
Yes.
So, okay, thank you. Any other questions or comments from people listening? Anybody want to chime in? I think we have thank you so much, Talia. Anything else to say?
Well, yes. I was receiving compliments after that one exosome treatment on my spine. Friends were telling me that I looked younger or better, you know, and I thought, well, maybe the exosomes went to my face first and then they sort of moved more around my spine.
I love it when people accuse you of having something done, you're frenemies. That's great. Terrific. Well, thank you so much for joining in. I really appreciate it. And I'm so glad that you sat next to Mom and you were able to get a treatment back then. So that's great. I'm going to actually, Dr. Greg Gerber's on the call. Thanks, Talia. Appreciate it. I'm going to go ahead and see if Greg has anything he wants to say to us.
Unmute.
There he is. Hey, Greg.
Hello there, sir. Delighted to hear your presentation.
Oh, good.
You are exceptionally articulate, do a beautiful job, even if you aren't a physiatrist.
Well, Dr. Greg Gerber, I've known for probably 8 or 9 years. He started taking the TS65 and it helped him a bit with his swimming. And so he is a physical medicine and rehabilitation medical doctor and living in Hawaii. So anything in there that you want to add to or even contradict in the presentation?
No contradiction, just a question.
Yeah.
I have several patients who have Cauda equina.
Yeah.
And have you had any experience with Cauda equina? Because one of these people I have in mind is looking for a life care plan, and I'm trying to figure out those things which will avoid surgical intervention for him that should be explored before he would even consider things of that nature.
Cauda equina syndrome, of course, that's kind of what we're talking about, compression of the horse's tail. Do you know what the cause is in his instance?
Well, one was a traumatic and the other was a congenital, and they're males and they're causing sexual dysfunction, bladder incontinence issues.
Yeah.
So fairly fairly deeply complex issues.
You know, initially when someone asked me a year ago, I was at a reunion and they said, "Oh, my dad has spinal stenosis," actually a famous actor. And I kind of was hesitant because just in my sort of crude thinking, I'm thinking, well, if this stuff is regenerating bone and the bone canal is already narrow, maybe it wouldn't be safe. But now that I think more deeply about it, it's not really that the canal is going to get smaller. We hope that the ligaments will tighten up and do their job. The muscles will heal and relax. And so the functional unit will straighten out. So that's kind of the paradigm under which I'm working. But, you know, I don't have a lot of specific people with that degree of stenosis leading to Cotta-Equina syndrome. But intuitively, you'd think, well, if you're bathing the whole region with stuff that's regenerative, anti-inflammatory, that the constant bone remodeling, the ligament regeneration would be a good thing. But I would say proceed with caution and maybe give it a try.
I was out there just, you know, like yourself. I like to see the new that's coming forward and that which will offer people with insolvable problems some possibility of hope to move forward with a more functional life. So
Yeah. Well said.
that would be my only comment, and
Thank you.
a pleasure to see you at least on screen, and hope to see you sometime in person sometime
Yes.
within the next couple of weeks or so.
I know. I'm ashamed to say I've been here 5 weeks and I've not been in the ocean yet, but maybe this afternoon.
I'll see you out there, okay?
All right, great. Take care.
Thank you.
Aloha.
Aloha.
Thanks, everybody. It's Dr. Ed Park finishing up webinar number 2 on back pain. Next week, same bad time, same bad channel. We're going to do shoulders. So hopefully you can join us for however much time and we can get to your questions at the end. Okay. Thank you very much. Aloha. Bye-bye.